irreparable rotator cuff. So what is a massive irreparable cuff? Massive cuff is when more than 2 tendons and what's very significant retraction. So, and retraction means, so when the cuff after the tear slowly starts going back, so that is called retraction. So there are 3 grades of retraction. So I was asked to keep the talk very plain and simple. That's why I will not be explaining this. So I can explain it here. So the muscle, once over a period of time, starts retracting back. So it starts from the edge of the tuberosity GT, and that's called grade 1 retraction. Then little more back on the head is called grade 2 retraction. And then gradually, when it comes near the glenoid, it's called as grade 3 retraction. So that is point indication. So that means it is really retracted and chronic. Then there is something called as fatty infiltration. That means amount of fat which is there in the muscle. So you can, there's a Gautier classification for this fatty infiltration. So the more the fatty infiltration, so you can make out in the MRI, and that is in grade 3, grade 4, that is the fatty infiltration. You know that it is going to be irreparable. So this is a technique for that. So I work at Manipal Hospitals, Whitefield, Bangalore. I am adjunct faculty at KMC Manipal as well. So this is the SCR. So you can see that there is a bridge of tissue. This is the facial ladder. So I will tell you how much of facial ladder is taken. So it is taken and it is bridged between the GT and the superior glenoid. And the remaining muscle, which is the infraspinatus, and the remaining muscles have to be attached to it. And this has to be fixed very sturdily back to the GT like this. So this is the SCR. So how does it work? There are 2-3 principles of the SCR. So the funda is that, so this is the head, this is the glenoid, and this is your acromion. So here, whenever there's a massive retraction, this acromion, the subacromial space reduces. So Dr. Hamada classification, Sugaya, has classified this as what is the grade of arthritis or degeneration. So here, what happens over a period of time, this goes up to, that is proximally migrates. So this proximal migration decompensates the mechanics of the shoulder, and eventually patient is not able to lift. So here, when you put a spacer here, like got a striker balloon, so this basically brings it down and creates a space and centers it on the glenoid so that a normal rotation of the deltoid happens. So this is the spacer effect. Next, the trampoline effect. So that means the head, it's a reverse trampoline ladder. So it goes in like when you put a spacer there, it's kind of like this, and it kind of bounces and rotates. Then lastly, something called the force coupling effect. Because just putting that is not enough. You need to add some forces there. So what forces are added? You can see that the remnant cuff has to be definitely integrated very well into this, and that's called side-to-side repair. Now, talking about side-to-side repair, so you might think, okay, we should do an anterior side-to-side. What is anterior side-to-side? You have to close a rotator endum and subscap to the facial ladder. Then, from facial ladder to the infraspinatus, and remnant to the supraspinatus to the facial ladder. So, mechanical studies have shown that this posterior side-to-side is the most important in this process, and the anterior is not very important. The posterior side-to-side gives a force coupling as well as stabilizes the mechanics a lot. So then, coming to the MR, so this is a typical MR which you see. You can see that is possibly a U-shape there. You can see this anterior, you can see a significant retraction. You can see this is called it's going a significant retraction in the muscle here. And gradually when it comes posteriorly, you can see it is slightly like coming to grade 2. That means here the anterior most is, it's like a U. The anterior most would be significantly retracted. So that's how you make out from this. And then you can see this, the atrophy. The atrophy, what you can see is, this is a scapula Y, and in this particular view, you can see that the muscle is definitely below this level. And you can see the amount of frequency specs back infiltration. And then, what is another important factor for me is the biceps. So you definitely look at the biceps. The biceps is there or not. Yesterday, we were seeing the live surgery, I incorporated along the muscle side of biceps. So here, biceps is very important for me. So we can do the bicep SCR. Additionally, you put it as an additional band under the fascia lata that increases the thickness of the thickness of the graft as such, and it is a natural graft. So biceps according to me is God given to shoulder surgeons to fix it. You can use it anyway. You can do DAS, you can do augmentation, you can do SCR, whatever. So use the biceps. So now we'll go through a typical video. So this is a patient who had come to me, and you can see the glenoid there, and you can see the head is bald, and you can see the biceps also sitting there. Even though it's a degenerate, you can see the remnant of the rotator cuff which has gone behind, that's also there, and that's what you see on top of the abdomen, 12 o'clock position. And you can see again that the root of the bicep is degenerate, but doesn't matter. This is not a loading biceps, so it is better than putting a graft. So still you can use it. So just clearing up the subacromial space, and then you debride the head of the humerus, and then you also have to medialize it. So here you can see that I'm making nice indentations on the head because you need the real vascular bed. It is called moon crater. So it's like you have to make the surface like a moon crater. This is a terminology I got from Professor JCU. And then you start mobilizing the rotator cuff. Here, what I'm doing is clearing up the subacromial space again. That is the posterior part of the subacromial space. You can see the fat layer and the muscle layer there. And then you also start having to do the supraglenoid release. So what is supraglenoid release? Above the glenoid, you need to go and slowly elevate it. And you have to be careful. You can go up to 10 mm, and beyond that, the nerve comes into play. And next is the cuff releases. So you can see the muscle is still back, it's not coming up.